So can we start now?
We are live now, doctor.
So shall we start?
So shall we
Doctor,
start?
doctor.
So good evening, ladies and gentlemen. On behalf of Saudi Heart Association and GSK, I am pleased to welcome you all to this valuable and timely webinar discussing one of the most important adult vaccination in cardiovascular patients. As healthcare professional, we understand that cardiovascular disease remain a leading cause of mortality and morbidity worldwide. What often underestimated, however, is the critical role vaccination plays in protecting our patient, particularly those with underlying cardiovascular disease, from preventable infection that can furtherly complicate their condition. Today's session brings together esteemed experts who will shed light on the current guideline, evidence-based practice, and clinical importance of shingles vaccine and shingles burden on cardiovascular patients. We encourage you all to submit your questions through Q&A, and we will address them during the discussion segment. And now let's begin with our speaker, Dr. Hatem Khairallah, consultant cardiologist and echocardiologist at Prince Sultan Cardiac Center, academic coordinator and deputy director of adult cardiology fellowship program at Prince Sultan Cardiac Center. Let us welcome Dr. Hatem. Dr. Hatem, welcome.
Thank you so much, Dr. Faiza. Thank you, and thank you for our audience and organizers. And I'm going to share the screen now. So just assure me that my slides and voice are coming through okay. Okay. So the cardiovascular disease and shingles. It might appear a bit strange for a cardiologist to come over here and discuss sort of infection and vaccination, but I'm gonna clear this kind of confusion in a bit. These are my declaration. Right from antiquity, there was a focus on prevention, and Hippocrates is quoted as saying, the greatest medicine of all is teaching people how not to need it. And we're all accustomed and familiar with prevention is better than cure, which is a time-honored golden piece of advice or wisdom. And this prevention is better than cure, not in terms of medical care, but also in terms of health economics at large. And the hilarity of the present time, Dennis Burkett hilariously quoted, if people are constantly falling off a cliff, you could place an ambulance under the cliff or build a fence on top of the cliff. We are placing too many ambulances under the cliff. So this is underscoring that our paradigm so far is more into the treatment than prevention. And this mindset or paradigm should shift. Now, for vaccination, we have just received a consensus statement a few weeks ago from European Society of Cardiology emphasizing the role of vaccination as a new form of cardiovascular prevention. And here, the abstract, vaccination is increasingly acknowledged as an effective preventive measure, not only against a specific infection, but also for prevention of cardiovascular disease in high-risk diseases. So when we are vaccinating these patients, we are not only targeting the infection, but we are also targeting the major adverse cardiac event relating to cardiovascular diseases. So beyond prevention of infection and its sequelae, vaccination have profound effect on cardiovascular risk, and as such should be considered the fourth pillar of medical cardiovascular prevention besides antihypertensive, lipid-lowering medication, and hypertensive medication. And international guidelines should support this concept and act accordingly. So here we are. We know that infection has implication on the cardiovascular health in so many different ways, and especially in susceptible risk group who are having comorbidities and cardiovascular disease. When they are prevented for infection, they reap more benefits than the healthy individual with no comorbidities. And here are the graphs for vaccinated patients who have in the risk group and vaccinated patients who are healthy, not in comorbid group. So that emphasizes that the high risk group of cardiovascular patients are more at benefit, and they are going to benefit more from prevention and vaccination. And this is important South Korean study, which has published recently, and they have used live zoster vaccination in over 2,000 patients, and they followed them down the line for over 8 years. And the vaccinated versus the unvaccinated across a wide range of cardiovascular metrics and attributes. And the vaccinated patient fare much better than the unvaccinated patient in all of these metrics and attributes. So what is the immune system and the heart, the relationship? Now we have the cardiovascular immunology. We know that the immune system lies right in the center of cardiovascular diseases. So if we take atherosclerosis, for example, we know that there are so many immune modulation and immune markers that plays a role in the plaque vulnerability, stability, perforation, rupture, acute coronary syndrome, all of that. The same applies to myocarditis. Myocarditis centrally is an immune mechanism. The same applies to dilated cardiomyopathy, which has a lot to do with immunity and autoimmunity and different immune injurious agents. So the infection and the heart has been has been a field of heavy research and debate. And now, beyond any reasonable doubt, we know that the infection induces a pro-inflammatory effect. And that might be the reason of cardiac influence of infection through this mechanism. It is, honestly speaking, it is multi-mechanistic. So there is no single factor, okay? It's probably alliance of different factors that leads infection to affect the heart in so many different ways. So the inflammatory effect of the infection is one. The prothrombotic effect of the infection is another factor. The increase in myocardial oxygen demand due to the infection inducing hypercatabolic state and hyperadrenergic state, increasing the heart rate, the blood pressure, the contractility, all of which consumes more oxygen, and that might precipitate ischemia. There is also the molecular mimicry between the antigens of the infection that might cross-react with the heart tissue. Sometimes there might be direct vasculitis or myocarditis due to the infection, and the role of infection in decompensation. And the role of infection in decompensation has been studied carefully and thoroughly in so many studies. And this slide is probably so familiar to any cardiologist. We all know that in any patient of heart failure in a stable condition, once he or she decompensates, hospitalized, we get him out of the decompensation, but we put him in a new baseline, which is lower than his initial baseline. So he is never back to his baseline. With each and every decompensation, there is down course or downhill course in terms of mortality. And what decompensate the stable heart failure patient, infection is playing a crucial role, among with other factors. So here also is the role of chronic inflammation So chronic inflammation has been also studied thoroughly in so many studies and has proven beyond any reasonable doubt to play a pivotal role in atherosclerosis, vulnerability of atheroma, and plaque rupture, which is the inciting event of acute coronary syndrome. So what is the relationship between cardiovascular disease and shingles? And that is why a cardiologist like myself talk about shingles, because there is an avid correlation or relationship which is kind of reciprocal and mutual. So the cardiovascular disease affect the immunity in so many different ways. So it leads to dysregulation of immune pathways and inflammatory pathways. It accelerates immunosenescence, okay, whatever the cardiac condition is. But this has been seen more with some cardiac diseases than other. So like acute and chronic coronary syndrome, ischemic heart disease, and heart failure probably score the highest in terms of their affliction of the immune system. So by and large, cardiovascular disease, especially heart failure and ischemic heart disease, undermine the immune system through many different pathways. And these pathways might include monocyte macrophage metabolic dysregulation, increased expression of immune inhibitory surface antigen or surface protein, and also defective adaptive immunity and inhibition of T cell activation, proliferation, and effector function, all of which will predispose patients to infection. So this is how cardiovascular disease as such undermine the immune system, predisposing patient to infection. So there is higher risk of shingles, and shingles is no exception. So many infection, and that's why influenza vaccine has been and still is class 1 indication in the treatment of cardiac patient, okay? They have to be prevented from influenza in particular because they are more susceptible to get influenza due to their weak immune system. So it is not only shingles, it's all infection. But as far as shingles is concerned, there is 34% increase relative risk of developing shingles in patients of cardiovascular disease. And this is pretty high figure, okay? On the flip side of the coin, and this is also important, and this portrays the bidirectionality between shingles and cardiovascular disease. So now we know how cardiovascular disease predisposed to shingles. Now what shingle does in a patient of cardiovascular disease? It increases the risk of stroke 78%, risk of MI in the first month 25%, risk of arrhythmia within 2 months of infection 22%, and increases the risk of coronary artery disease within 2 years 14%. So these are really alarming figures, If we have an increased risk of stroke of 38% in the first months of shingles and 25% risk of MI 1 month after shingles, we really have to be cautious and we have to be proactive and deal with these figures proactively. So what is shingles? I actually have been forced to study shingles from this side. It's how affect the cardiovascular patient, okay? Otherwise, I'm not an ID consultant, and Dr. Faiza is here to clarify some points. So the varicella, which is chicken pox, after the childhood infection, it stays dormant in the dorsal root ganglia forever. So there is a long latency period, okay, which can be reactivated through many different ways and means, some of which are speculative, but by and large are not so well understood. And this reactivation of the latent virus in the dorsal root ganglia lead to zoster infection, shingles. How many patients are having varicella zoster virus in the dorsal root ganglia? That means how many patient has been afflicted any time in their life with chickenpox. And this is at least 90%. And this comes to the surprise of no one of us in this room, because any one of us probably remember he himself or herself, her neighbor, sons, kids, and co-workers who have chickenpox. It's pretty common infection. So 90% of patients more than above the age of 50 are infected with varicella zoster virus, and therefore they are at risk of shingles. How many of them are going to develop shingles? According to studies, 1 in 3. 1 in 3 of the patients who have varicella zoster will have reactivation at any time in their life and get shingles. So overall, the rate of shingles is 6 to 8 per 1,000 patients at the age of 60, and there is 1 million new cases of shingles in the United States annually. And in Saudi Arabia, 44% cases of shingles are in the age of 50 and above. So the age has a lot to do with shingles. And here we are. If you look at the age, there is a steep rise after the age of 50 in the rate of infection and also in the rate of complication, the most important of which is post-herpetic neuralgia. That's why the majority of the guidelines, the locus of focus is the age of 50 and above for vaccination. So what makes the reactivation? The chickenpox, which is probably a childhood infection, is beaten by cell-mediated immunity, and it is cleared from the skin, but the virus remains dormant in a hibernation state in the dorsal root ganglia. And as far as the immunity, the cellular immunity is higher than shingle threshold, which is kind of theoretical, the virus remain dormant. But as age advances, we know with age advances there is immunosenescence. So the cellular immunity at one stage or another is going to drop below that threshold. So the virus is going to get activated and shingles will appear. So what is shingles? Shingles is unilateral vesicular rash in a dermatomal distribution, okay? And the pain is expressed as excruciating, burning, aching, stabbing, shock-like. The complication, the nastiest of which is post-herpetic neuralgia, in which a neuropathic pain persists more than 3 months after the infection. And unfortunately, it affects up to 30% of patients of shingles. So almost 1 in 3 patients of shingles will develop post-herpetic neuralgia. Another unpleasant complication is herpes zoster ophthalmicus, affecting the distribution of the ophthalmic trigeminal nerve. Fortunately, it leads to blindness in very rare cases. We can also have constitutional symptoms in form of headache, photophobia, malaise, and fever, and we might sometimes have more disseminated infection. Herpes zoster symptoms may be more severe, and the complications are more frequent and more severe in immunocompromised patients. So what about the pain of shingles? Now, if we put the pain in a pain scale and we see questionnaire of patients, different patients, shingles score really high among the acute pain and chronic pain. So it is a pretty much pain. Isn't that tolerable? It's severe pain. And pain for all of us as physicians is kind of an important trigger to our care, especially we in cardiovascular medicine. We know that pain is not only pain. Pain triggers adrenergic response, inflammatory response. It leads to tachycardia. It elevates the blood pressure. It might induce a sort of stress-induced cardiomyopathy, tachycardia-induced cardiomyopathy, tachycardia-induced ischemia, and so on and so forth, especially when it's chronic and debilitating. So pain by and of itself affects the cardiovascular disease through the responses it generates. And here is the quality of life affected by shingles and pain. And according to patient reporting, the quality of life metrics, 95% are having affect their emotional functioning. 28% affect their cognitive functioning, 63 social functioning, 78 physical functioning. So this is enormous problem. Pain, chronic pain, how much it affects the quality of life, how much it affects the emotional functioning, and stress, and the stress induced problem that can precipitate or can lead to accelerated atherosclerosis, can lead to decompensated heart failure, can lead to stress induced cardiomyopathy. Again, physical dysfunctioning will force the patient into house arrest, forced sedentary lifestyle, with the implication of that. So these dimensions of quality of life being affected so gravely by this disease is so alarming, and we have to really take care about patients of this disease. Now, the good news is, as far as physicians are concerned, we are still influential as advocate of patients, as serving the best interest of the patient, as the patient being responsive to us the most. Considering all other factors the patient are affected by, we are really so influential. So if just the vaccine kind of persuasion is 25%, it increases to 74% if it comes from a physician advice. So the physician advice is paramount. And this comes from a historical relationship of patient-physician, which has been an enduring relation for ages, and the patients and the physician are mutual trust is so important. It's not like general, this is kind of personal relationship. So when an advice comes from a physician to his patient or her patient, things are definitely so different. But the flip side, that puts a heavy burden of responsibility on our shoulder to beat the so-called clinical inertia. So we have to wake up and we have to do whatever it takes. We have to be active and proactive, and we never go through the lines of least resistance, fixating on treating our patient by medication, but it has to be part and parcel of our responsibility to ignite a discussion about preventive measures in every and single clinical encounter. So what is Shingrix, which is the vaccine we are discussing here today? ZOE trial is a very large trial, but before that, what the vaccine is about? The vaccine is a combination of a recombinant antigen glycoprotein E and adjuvant system. This adjuvant system enhances, its kind of immune stimulus, so it enhances the potency of the vaccine and durability of the vaccine. So ZOE trials, we have ZOE 50 and 70. So it is studied in patients of 50 to 70 years and of 70 years and above. And there was 16,000 in this group and 14,000 in this group. And the study included 18 countries, and it was randomized, placebo-controlled, multicentral, multinational study. And look at the figures, they are speaking of themselves. Look here, we have 97% efficacy against shingles in patients above the age of 50, and 97.9 above the age of 70. And even above the age of 80 is still a robust figure of 98.4. So this is very potent vaccine, no doubt about that. And the durability of this effect is as far as 11 years. It wanes a little bit after the 8 years, but it remains robust up to the 11 years. And of course, it's given in 2 doses, 2 to 6 months apart. When we zero in on cardiovascular patient, like in a hypertensive patient of dyslipidemia and coronary artery disease, again, the preventive level is as high as 90 and 97%. So cardiovascular patient reap the same benefit out of this vaccine, no exception. And more objectively, probing more objectively in Shingrix vaccine, we see that after the second dose, the level of the T cell increases 4 times its baseline. So we are seeing that in immune metric type and in clinical type. Clinically, the prevention from shingles, but even when they measured the T cell count, they found it 4 times higher than its baseline after the second dose of Shingrix. Now, our all concern, we are all as physicians concerned with the safety profile. The efficacy has been discussed thoroughly and is proven beyond any reasonable doubt that it is efficacious. But that's not enough for its prescription. We have to ensure safety. Now, for safety, serious side effect, death, and potential immune-mediated diseases, the vaccine versus placebo, there was no difference. There was no difference. The only thing is that, and we really have to be honest about it, is the immunoreactivity or immunogenicity reaction. There are kind of different reactions, nothing serious, nothing fatal, nothing long-term. But pain at the injection site, redness, swelling, myalgia, fatigue, headache, constitutional symptoms, GI upset were at least like mild to moderate kind of incidence. Okay, so this is important to assure our patient that he or she might experience these symptoms, so he or she shouldn't worry about that. Okay, but these are common symptoms, all of which are mild and transient and short-lived. Now, what about the guidelines? In Saudi Arabia, MOH National Immunization Program recommendation, it recommends 2 doses, 2 to 6 months apart for adult age 50 or older. And the indication of Shingrix for prevention of herpes zoster, post-herpetic neuralgia in all patients above the age of 50 and below the age of 50 if there is an increased risk of herpes zoster like immunocompromised patient. In USA, CDC and ACIP recommended 2 doses of Shingrix separated by 2 months for immunocompetent patient at the age of 50 and older. So the same as in Saudi guidelines. So here we are, if you wanna scan this barcode for further information about it. And last, I'm gonna conclude with a quote by Michael Spector: universal vaccination may well be the greatest success story in medical history. Thank you so much.
Thank you, Dr. Hatem. Thank you for this insightful presentation. We truly valued your time and the way you break down the complex idea and made it easy to understand. ما تفكر تحول ID دكتور حاتم؟
That's a tough one. I can't, yeah.
لا يعني a great lecture صراحة ما ودك تحضرها لنا في الكاردياك سنتر عشان تصير أنا لايف lectures.
Sure. Thank you
إن
so
شاء
much.
الله على خير. I can't see any questions here in the Q&A, but maybe we good to tell them that Shingrix vaccine is available in cardiac center under preventive medicine, and we are planning soon to bring it as a campaign. It's also available in National Guard, King Faisal Hospital, and Ministry of Health, also in private hospital like Al Habib, Dalla, also did everywhere it's available. So it's a good opportunity for to advise your patient to take it.
And if I ask you, Dr. Faiza, from your experience about this immunoreactivity kind of side effects, are they as common as in the Zoe trial?
You mean the side effect?
Yeah, like pain, swelling, and malaria, fatigue, and all of these.
It's really not significant. It's similar to the other vaccinations, يعني, side effects. It's not that prevalent that to prevent taking the vaccine. So weighing risk from benefit, yes, we would recommend to take this vaccine to prevent shingles as a disease. And this side effects, it can be tolerated. It's not more than the other usual vaccine that we take it annually, like influenza and other vaccine.
Exactly. Exactly. And I remind the audience that sometimes side effects is the cost we have to pay. We know that, like from COVID vaccine, there were cases of vaccine-induced myocarditis. That is for sure. Okay. But now all studies has shown that COVID myocarditis, the incidence of which is 6 times the incidence of vaccine-induced myocarditis.
Yes.
Whatever the case is, vaccination is better than no vaccination.
So thank you, Dr. Hatem again, and thank you for GSK and Saudi Heart Association for this supporting for organizing this webinar and supporting this initiative regarding vaccinations.
Thank you so much. Thanks.
Thank you, Dr. Hatem.
Thank you, Dr. Faiza. It was my honor. Thank you, all of you.